Forwards and forwards. There is a old myth about the diabetes that it is the mother of all the diseases. ये एक ऐसी अम्मी हैं जो कि जान ही ले लेती हैं. That is said about the diabetes. And I want to invite Professor Sanaullah, please come over the dais and deliver a lecture about the diabetic retinopathy.
Good day to everyone, and thanks for moderator Dr. Sanaullah, जो आपने बात की. मेरे ख्याल में इससे ज़्यादा अच्छी बात डायबिटीज़ के हवाले से इंफॉर्मेशन कोई और नहीं हो सकती आज. लंच का टाइम है, लेकिन गज़ल तो सुननी पड़ेगी और एक्टिवली सुननी पड़ेगी, इसलिए कि आई विल बी नॉट जस्ट शेयरिंग इंफॉर्मेशन but asking questions at the end. Okay, so we will be talking about diabetic retinopathy. I don't have any financial disclosure regarding this presentation. Diabetes is a global epidemic and global challenge which all our healthcare individual and especially eye care individual has to deal with. It is estimated that 642 million people will be affected by 2040. One simple figure I would like all of you to remember regarding diabetic retinopathy is the figure of 1/3. If there is a diabetic population, 1/3 of this diabetic population will be having features of diabetic retinopathy. And then among these individuals having features of diabetic retinopathy, 1/3 will be having features of diabetic retinopathy which will be threatening to the vision. And they may need intervention in a form of anti-VEGF, laser or surgical intervention. We did some hospital-based studies, and we found that in 2003 we reported that 17% of our diabetics in eye outpatients are having proliferative diabetic changes. This figure was same in 2018 also. 20% of our patients presenting to retina clinic were having proliferative changes. Then, in endocrinology department, we had one study, and it showed that 6.3% of diabetics presenting to endocrinology unit are having proliferative diabetic retinopathy. Now, we know that for decades, after recommendation from diabetic retinopathy study and early treatment diabetic retinopathy study, PRP was the standard protocol for proliferative changes. With time, it was found out in diabetic retinopathy, main focus was on diabetic macular edema. When these anti-VEGF came out on the scene, they were tried for DME, and it was found that while treating DME, the patient with coexistent proliferative changes, they also showed resolution of new vessels and proliferation. So this led to design of Protocol S of diabetic retinopathy clinical research net. In this Protocol S, they compared PRP versus anti-VEGF injection plus deferred PRP for proliferative diabetic retinopathy. It was multi-center randomized controlled trial, and in 2015, 2-year results were presented. It showed that there is better visual function preservation in the group treated with anti-VEGF group in terms of visual acuity and also in terms of visual field. In 2018, 5-year results were presented in American Academy of Ophthalmology. And what were the results? You can see at 6 months, the visual functions were better preserved and it peaked at 6 months. At 1 year, it was maintained. At 2 years, the difference was still statistically significant. But down the line, at 5 years, the visual functions were the same in both groups, the anti-VEGF treated group and the PRP treated group. The reasons were not obvious. Okay. Complications were same almost, but the PRP group, they had more chances, the PRP group had more chances for going for vitrectomies. Safety profile was similar in both groups. Now, how do we treat our patient? We got different socioeconomic conditions. The cost, compliance, risk factor awareness, control of diabetes, everything is different. In one of our studies, we found that only 20% of our diabetic patients who presented to IOPD, they were having good control of their hyperglycemia. Only 20% had awareness about any other risk factor besides hyperglycemia for diabetic retinopathy. And 70% will present to you with complication of diabetic retinopathy or with some irrelevant symptoms which are not related to diabetic retinopathy. Only 1/3 presented to ophthalmologists because they were referred by physician, endocrinologist or general practitioner, or they knew about diabetic retinopathy and its blinding sequelae. Now, cost matters. In Pakistan, in our country, by anti-VEGF we means Avastin, and that is because it's the cost which is involved. One of my estimates which I did about diabetic retinopathy, that the budget which we require to treat just only this one disease is about 500 to 600 billion, which is almost half of our national defense budget. Now, what treatment option we have? Risk factors? Yes, of course we have to control. That is the main thing. Then anti-VEGF, 3 anti-VEGF are in the market. It is the Lucentis, Avastin and IER, and lasers. This is one of the photographs. Okay, the PGs, anyone who can comment voluntarily, how will you treat this patient? These are new vessels here, pre-retinal hemorrhage, center involving diabetic macular edema. Keeping the protocol as recommendation, how will you treat this patient? Anyone? Sir? Any senior faculty member who would like to comment? Pardon? Center involving macular edema, I'm telling you. Please. Proliferative diabetic retinopathy with center anti-VEGF because they are having better. Okay. This is because in protocol as well there was DME center involving. So you need to treat that DME with anti-VEGF. So the coexistent proliferative retinopathy will resolve by itself together with the anti-VEGF treatment. You don't need to go for PRP in these cases. So better option is anti-VEGF, agreed. But if the patient is having poor compliance, he cannot come, or the cost is, matters for that patient, then you can also go for PRP because ultimately 5-year results are the same. Now, another patient, proliferative changes with no DME. Anti-VEGF or laser? No. There is no macular ischemia. Proliferative changes and no DME, PRP. But as we already discussed, for the first 2 years, the patients are having better visual function preservation in the group which were treated by anti-VEGF. So again, anti-VEGF is first, because if the patient can come for compliance, if he is compliant with the treatment, and if he is not very low socioeconomic status, then probably he should get the benefit which the protocol has recommended. Again, if there is poor compliance, you can go for PR. Okay. Diabetic non-center involving diabetic macular edema with PRP history, which is not very obvious. You can see new vessels and edema, but non-center involvement. How do you treat this patient? Tightening of PRP, further PRP, or anti-VEGF? Yes. Again, because you have to individualize every patient. You can't, there is no rules here now. You have to individualize the patient for your treatment of, for selecting treatment options. Sir. So here again, you can go for anti-VEGF injection. If you can see that there is some space there and you can fill that with laser, then you have to do the laser first. And still, if there are new vessels, then you can aid anti-VEGF to this treatment. This will be mild. Again now, proliferative diabetic needs, NVD, and some traction which is there along superior-temporal arcade. There is history of PRP also. You can see the scars there. How do you approach this patient? क्या करेंगे इस? They say this patient is 6/6 vision. The fovea is normal. Would you like to still go for the surgery? Yes. PRP. So first, exactly, you have to go for further laser. As fibrosis is not absolute contraindication. You should keep that in mind. If it is away from macula, still there is chance you can go for one, or if needed, 1 or 2 injection. But you have to be very vigilant. First, you have to go for PRP grade. This one, proliferative changes, very extensive, NVD, NVD, retinal damage. How you approach this patient? Exactly, because the combination group, studies have shown that they have better resolution of new vessels compared to treating them with one option, PRP or anti-VEGF. Okay, this is proliferative diabetic retinopathy, NVD, DME, and PRP done, but there is macular edema. Anti-VEGF, further laser. Okay, if there is space, but they're probably very nicely done, but if there is space, you can still go for laser, but anti-VEGF probably you have to continue in this patient. This one, vision 6/6, fibrosis. There is some vascular element also, and pre-retinal hemorrhage. Surgery, anti-VEGF, PRP. Go for surgery. 1 or 2 gauge further laser in the periphery, away from the fibrosis. Endolaser will be surgical intervention. So, if you are planning for, if this patient is enjoying 6 vision, I would first go for laser and stabilize. If the new vessels regress, I will just observe and let him enjoy the vision. If there is increased fibrosis, if there is macular involvement, then I will go for surgical intervention, and of course before that I will inject anti-VEGF. This one, boot-shaped hemorrhage, pre-retinal. क्या करेंगे? अगर डॉक्टरी सर्जिकल इंटरवेंशन, पीआरपी, एंटीबायोटिक हो गया, इन्वॉल्व नहीं है, वो ठीक है, इसके नीचे है, पीआरपी नहीं हुई, याद करेंगे बिल्कुल, लेकिन याद से पहले पीआरपी करेंगे। अगर आप याद करेंगे तो ये ब्लड पूरे विट्रियस में फैल जाएगा, डिफ्यूजली स्कैटर हो जाएगा, फिर आप पीआरपी नहीं कर सकेंगे। पहले आप पीआरपी करें, फाइब्रोसिस ज्यादा नहीं है, जितना आप कवर कर सकते हैं, उसके बाद फिर याद करें ये डिफ्यूज और टाइम दे के अगर एग्जार्ब हो जाए तो। अदरवाइज सर्जरी की तरफ तो आप हर टाइम जा सकते हैं जो रिस्पॉन्ड ना कर प्रॉब्लम से। अच्छा, नाउ एक और रिसेंट स्टडी बेसिकली प्रोलिफरेटिव डायबिटिक रेटिनोपैथी के मुतालिक जो आई है, वो डायबिटिक रेटिनोपैथी क्लिनिकल रिसर्च नेट प्रोटोकॉल ए भी है, जिसमें विट्रियस फील्ड में प्रोलिफरेटिव डायबिटिक चेंजेस के साथ 100 पेशेंट को सेलेक्ट किया गया, इंक्लूड किया गया, और आईआर को ट्राई किया गया वर्सेस विट्रेक्टोमी विद एंडो लेजर पीआरपी। At 2 years, no significant difference. Final visual acuity score was similar in both groups. But here, vitrectomy group had faster initial visual recovery compared to anti-VEGF group. IER group, 33% required vitrectomy during study period and follow-up, compared to 8% which initially had vitrectomy. So both are viable first-line option for vitreous bleed due to proliferative diabetic retinopathy. This was conclusion from AB protocol. Now, there's a lot of things in the pipeline. Most of the drugs, medical therapies are focused on diabetic macular edema, but two studies, Pavilion and Altitude, they are also focused on diabetic retinopathy. Altitude, in it, they use virus vector to deliver a gene encoding an anti-VEGF monoclonal antibody fragment. Vector is delivered into suprachoroidal space. Type 1 and 2 diabetes patient, visual acuity of 20/40 with no diabetic macular edema patients were included. Primary endpoint was improvement in diabetic retinopathy severity at week 48 versus observational controls. It is still ongoing and we are anticipating the results in 2021. Pavilion is port delivery system with anti-VEGF versus intravitreal anti-VEGF injection. In moderately severe or severe non-proliferative diabetic retinopathy changes, and patients with DME were excluded. The primary endpoint will be percentage of participants with improvement of greater than 2 steps from baseline. Pavilion is actually going on and has aiming to recruit 160 patients. Then there is protocol W of that DRCR-NET. Anti-VEGF, they are trying in severe non-proliferative diabetic retinopathy, just to know how many gets vision threatening outcomes like proliferative changes or diabetic macular edema. And results are expected in 2022. Then protocol AA, ultra-wide field fundus imaging versus early treatment diabetic retinopathy study standard field imaging for assessment of diabetic retinopathy and prediction rates for worsening of diabetic retinopathy. When 2-year results were available on the scene in 2015, I wrote an article in one of the journal editorial for that, and these were my statements. Anti-VEGF may soon become standard protocol for treating proliferative diabetic retinopathy, but it may not prove its cost effectiveness in developing countries. Second, treatment modalities may differ or continue to overlap in developing countries for longer than developed countries. Safety and efficacy of available option is debatable. Why debatable? Because we don't have local evidence. we need to produce our own evidence and data. So we need to individualize our patient with changes of proliferative diabetic retinopathy for selecting the right treatment option for a particular patient. And we should keep these things in mind: systemic risk factor control, cost of the treatment, compliance, and presence of DME. Thank you very much. Country is very beautiful, and we are among few of very privileged ones, but there are many who are not. So while practicing your profession, you need to care and keep the note of these unprivileged country. Thank you very much. Any questions?
Sir, you have talked about the protocol about AB protocol AB of drcr.net, in which there was any element of the fibrosis in which a sandwich was there, they were treating with the anti-VEGF only.
No, they actually, the fibrosis, patient with fibrosis were not included. These were the patients with DME, without DME, and proliferative changes.
Thank you, sir. Thank you, Professor Sanaullah. Thank you very much, sir. Now I invite Professor
Professor Sanaullah چې د پېښور یو دم مشهور پروفیسران څخه ده. هغه خپله وینا وکړه ډیابیټیک ریټینوپاثي باره کې.
In these COVID days, we were reluctant to come, लेकिन उन्होंने एक अच्छा एटमॉस्फेयर क्रिएट किया.